our guests and speakers for the next session to please join us on the dais. We have Lloyd, Senior Healthcare Advisor, IBM Watson Health. He is the keynote speaker. May I request Dr. Vijay Agarwal, President Consortium of Accredited Healthcare Organization India, who is the moderator. May I request co-moderator Dr. Shiben Ganju, who is the leading gastroenterologist. He is Chairman at Trimed Pharmaceuticals Limited, and he's also the founder at Save a Mother Foundation. May I request our speakers, Brigadier U.B. Mishra, Professor and Head, Hospital Administration, King George's Medical University, India. Our second speaker, Dr. Chandy Abraham, who is CEO at the Healthcare Project, ITC Limited, India. Our third speaker, Dr. Arati Verma, Senior VP, Medical Quality Mex Healthcare, India. Our fourth speaker, Kah Yee, Chairman of Eucharist Group, Malaysia. And our fifth speaker, Dr. Gurmukh Advani, Managing Director, Getting Group, India. I think still the lady is missing, I think. Oh, okay. I wish I could do that. Well, let's move on to our next session, which is Innovations for Hospital. Innovation in healthcare industry has its own challenges. Any attempt to understand the process of innovation must begin with in-depth analysis of these challenges. So let's start with hospitals. Hospitals are key stakeholders to bring systematic change in the health system in a country like India, specializing from optimizing the cost to improving the quality of care. There are around 500 accredited hospitals in the country. Majority of them are privately owned. Accreditation has provided a predictable framework for quality of care, and the private ownership of hospitals in India allows them to innovate faster. This differentiated from countries where healthcare is most publicly owned and pace of innovation might not be that fast. While India has its own issues and challenges, this session focuses on innovative solutions for the tertiary care in the country. When we talk of innovation, it's not just innovation per se, but diffusion of innovations is as important. And also, the market and environment should be ready for adoption. So let me give it to our moderator to take the session forward. Thank you, sir. Yeah, we'd like to apologize for that, but we...
Probably they are so well known.
Exactly. Thank you, sir.
Thank you, Swati. And it's my pleasure, along with my co-moderator, Dr. Shivam Ganju, to welcome these very illustrious panelists for this very important, I think, talk of innovations in hospitals and healthcare systems. What I would like to say is that, and in fact, a lot has been already said to make my task of introducing the topic very easy. The angle that I would like to say is, first of all, that for any innovation, we must also find out as to why am I innovating? There must be a reason, because you can't just do it for the sake of creating something new. And there, one would like to say that while in this country, there is, if you look at it like a pyramid, a lot is being done for the top of the pyramid. What we have to understand that if you see the ranking of the healthcare systems by WHO, you find that we are ranking at 112. Now this 112 probably might not have pinched me so much, but it pinches me when I find that a country like Bangladesh is rated 88, Indonesia is at 92, Cuba is at 39, we are at 112. So the issue is this, that we need to find as to why, when we are looking at that India has advanced so much into healthcare, so much is being done, but if you look at our infant mortality rate and you look at our maternal mortality rate, you look at the rates of stunting of children below 5 years of age, all those figures are abysmally high. There have been improvements. So what innovation we did was that we put our goals down. I mean, let's say United States has an infant mortality rate of something around 4. Our rates are hovering around 40. So all the developing countries try to put down, all right, our rate that we are trying to reach is around 40, so we can feel happy about it. The issue is this, that we cannot be happy. We need innovations and disruptions. Another thing is that what you find is, and what we heard, let's say, Professor Gupta, Anil Gupta in the morning, and he talked about a couple of innovations which are definitely earth-breaking. We are also aware about an innovation happening at All India Institute where this guy is talking about a low-cost ventilator which can cost around 15 to 20,000 rupees. The issue also is that sometimes these innovations start getting dust because there is no scaling up of the innovations to a level that the whole country can start to adopt it. And that's where probably you need a genuine, and genuine of person like, on the basis of which Arunachalam, the movie Padman was made, and you go through that whole story, and you require that it was not only his innovation, but a lot other effort that had to go into making that as a successful innovation and be adopted by the other people. I'd not like to stand much between you and the illustrious speakers. And first of all request Chris Lloyd, who is a senior advisor at the IBM Watson also, and at NHS. So Chris, over to you.
Thank you. Is my presentation being loaded?
Yeah, no,
Do I need to press a button? See, I'm very much used to having an instruction in front of me telling me what to do. I'm such a systematic person. Do we start the timer? Perfect. Thank you. Good afternoon, everyone. Just to show you, I am awake and I realise the clock has gone past the midday point. Dear colleagues, it's such a privilege to be here today as a non-medical person with so many influential, innovative, and world-leading figures in making healthcare a better thing from around the world. So I'm going to be very humble in what I do, but I'm also going to be very disruptive in my process. And one thing that I hope I can bring, without IT, is systems thinking to the process. So I really want to share some thoughts around innovation in how a whole country now needs innovation to solve its healthcare problems. And no, I'm not going to talk about India, I'm going to talk about my own country as we are here today. And what I want to do from today and tomorrow is to return with more new ideas to help influence the direction of travel towards a more affordable, high quality and safe service that is linking up with the NHS standards and the Constitution of being available at the point of need. So when we think about the UK, how many people trained in the NHS or worked in the NHS in their former lives? Could you raise a hand? Not so many. Normally the room's full of the hands. As we all know, it's a social care system. It's a very important system, but it is one that today is no longer able to meet its demand with the current capacity and the funding that it has. By 2021, we will actually have a £30 billion deficit in our funding, which is unaffordable. And unfortunately, we have a society which will not accept a rise in taxation to cover that gap. Our population is aging. We have significant development in long-term conditions. 2/3 of us are becoming overweight and obese. So actually, together with the challenge here in India, diabetes is becoming a very, very significant problem. A significant proportion of our population is aging. 1 in 12 of us will be greater than 80 years of age by 2039, with multiple conditions, with care needs, with affordability issues. And already 2/5, 40% of our budget is actually spent on the population that's over 65. Our medical professionals are at breaking point. There's a new term that came from the US called clinician burnout. Our doctors and nurses are getting exhausted, and today they actually depend on 10,000 doctors and 20,000 nurses from the European Union. From next March, it is totally unknown how many of those we will still have in our hospitals. It's a very, very serious problem. So if there was ever a case for complete innovation, this is absolutely the one that we need to think about. Our opportunities are immense. There is so much we can learn, but it requires a complete revolution in our thinking and in our transformation. We're not alone. Actually, one of my distinguished panel speakers is from Singapore, and in the US, we regularly see the healthcare commentators remarking that the Singaporean system and their strategy is something that many of us should follow. I've had the privilege to work in Singapore, as has Dr. Singh on many occasions, and we definitely see fantastic areas of opportunity and things that they've advanced in their care. However, this is creating its own problem internally there. They needed to have added 30,000 new healthcare professionals by 2020. They need to open 6 new polyclinics. They need to add nearly 20,000 hospital beds, daycare places, community places, and community facilities to keep this going. They're looking at opening a new hospital every year, which means there's a rise in cost and a rise in the situation. Many of you will probably know that Singapore has the second most rapidly aging population around the world, and in a culture which has a great dependence on the family members being carers, those carers are aging also. So clearly new ways of working are required. They share the same challenge with diabetes. Really, really frightening. They're predicting by 2050, over 1 million Singaporeans will be affected by diabetes. So the UK is not alone in its challenge. The Western world is facing a major challenge to have affordable healthcare. Every day we read about accountable care organizations in the US. We read about how they're driving towards their models. Every change in political leadership in that country creates a new set of challenges when the old idea is bad and the new idea is good. So there's a lot of uncertainty around the world in our healthcare provision. But let's return to the NHS. Thankfully, the leader of NHS England, who worked in the US for many years, so probably influenced by accountable care, he and the previous Secretary of State in the government and the new Secretary of State developed in 2015 a 5-year forward view, which has recently been published as a 10-year strategy. And that strategy is to develop integrated care systems based on population health management principles. So very much as we heard from our revered guests in the first panel, how do we get into prevention? How do we actually look at the causes of good health? How do we actually ensure that our very strained resources are able to be focused on the interventions that give the greatest value, both in terms of health outcomes and also in terms of affordability? And the two diagrams are very simple. On the left is the classic population health management pyramid. On the right is the vision of the NHS of actually how they want to identify patients or outliers of the normal conditions and work out how to treat them in the most effective way. The outcome is absolutely required is to be improved health. It's not a cost-saving exercise. It has to improve the patient experience because every day anybody who visits the UK will see on the BBC a bad news story about the NHS, a different hospital, a different department, a patient's story. There are in fact every week at least one documentary about a bad patient story, which is very demoralizing for the professionals in that industry. And also something very dear to my heart as a systems thinker, how can we create greater efficiency and productivity, not to fire people, but actually to have trained and doctors and nurses who are not stressed to cope with the growth in our population. But to do this, it's a bit like a Rubik's Cube. Many of us remember that child's toy in our infancy. NHS England alone, and remember England is only something like 58 million population of people, has 500 legal entities that all try and collaborate, and I say try, collaborate to procure and provide primary community behavioural health and acute and tertiary health services. It's an absolute minefield. So the NHS plan is to create 44, and they have created 44 sustainability and transformation partnerships, bringing together in partnership, not yet in legal entity, primary, acute, community, social services, which was formerly a local government department, and to focus on patient stratification and patient risk as opposed to the conventional speciality conditions that we undertake. So this is a major challenge that's going forward. I've spent the last year of my life working with my colleagues in IBM on trying to come up with and develop solutions for the NHS to go through that transformational journey, which begins with understanding the problem and then starts to bring in the technology to help us innovate our way into a new way of healthcare. There are many, many pictures of what the end game might look like. Many people may have heard of the King's Fund in the UK, one of a number of influential think tanks. Everybody can come up with some fantastic drawings and pictures of what integrated care might look like. No longer completely dependent on the hospital, but based on the community, closer at home for the patient, for their family, and for the providers of the care. In fact, we're now really encouraged to stop using the word patient and start talking about citizen. So we're no longer saying that we only think about the ill people or the sick people, we think about all of our population. However, what we find is still very much in its embryonic stage is the roadmap to achieve this end-to-end goal. That is something that there is absolutely very little documented and will be a voyage of discovery. So part of what we're all doing is learning from around the world, from India, from New Zealand with Canterbury, from the established ACOs in the US, and increasingly from the Nordic countries, which are beginning to really show fantastic leadership on how to prevent patients moving into the hospital and actually provide the care at the primary level and ultimately in prevention. So we heard some fantastic things about Sweden. I was surprised we didn't hear you on shopping, because that's one of my favorite councils in Sweden, which have made fantastic developments of their total healthcare. And we also know that Denmark has provided some fantastic services to really give fundamental service at the primary care level. And some of the results they have in almost reversing diabetes, if you will, from requiring hospital care to being able to be cared in the community is absolutely fascinating and important. And I realize they've given me a shorter time slot, so I will keep moving quite quickly through the process. So this isn't a lecture about population health management. It's an example of how the UK has begun to stratify and understand that information. So in primary care, we have experts that have come together and start to understand the population risk groups, to understand which of the patients are actually just in episodic care, which require enhanced primary care, which require extensive care. And the obvious goal is to prevent each patient group from moving to the higher level, which requires more treatment and a higher cost, and obviously is a greater burden in our society. But of course, the ultimate goal is to have the prevention. So if we look at the little table of the financial values, any health economist will absolutely know that the investment on the primary care physician working on cessation of smoking gives a 50 times benefit over actually the work we have to do on screening for diabetes. I won't go into the detail of this model, but it's something we designed a number of years ago in the NHS Wales. NHS Wales already have integrated care organisations. They've brought the primary, the tertiary, the social, the community, the mental health all together. They're working in collaboration with the social services, but their objective is to handle the primary number of patients at the area where the cost curve is the lowest. Again, it's not a financial cost saving, it's an actual recognition that providing care closer to home, avoiding the hospital admission, is a very, very powerful way of providing the best care in the best areas. And very quickly, the green blocks are services that are of lower cost. As we go from orange to red, they traditionally become more expensive. So the narrower the bandwidth of patients within the high cost area, the more affordable our services. And finally, innovation plays a huge part. Within Wales, they already have a fantastic opportunity to develop wellness villages using Internet of Things, using primary care prevention techniques, working on the American concept of patient activation so that everybody really takes responsibility for their personal health. And the objective, of course, is to keep replacing the conventional methods of providing our medicine with telemedicine, with clinical pharmacies, with the opportunity for online consultations particularly in geographic areas where the patients have to travel many miles to make a consultation. In fact, the head of the NHS said at a conference in the summer, the days of the outpatient clinic are numbered, the value they deliver is very minimal. We really have to look at what innovation and technology can do to help us provide that same service at a much lower cost and with a better utilization of our clinicians. So ladies and gentlemen, I'd just like to conclude and say, I now hope we can start to learn from what we're trying to change in the UK. That can provide some examples and ideas for you in India. And as I've always seen, whenever you take a really good, innovative idea, you take it much faster than the Western world. You take it more comprehensively than the Western world. And you create new ways of delivering that value that our conventional Western mindset finds very difficult to accept. So I very much wish you a very good conference, and I am sure that my following speakers on the panel will continue to develop the idea of how innovation in the hospital and the healthcare setting is an absolute primary focus for us all. Thank you.
Thank you, Chris. And I think the problems that you enumerated are, although very similar to, but on a very, very different scale. And to put the context, we must understand in our country, the rural healthcare picture is extremely bleak. Every 12 minutes, a young lady dies during childbirth. 3 lakh children die the day they are born every year. 1.2 million children die before celebrating their first birthday. So the kind of the problems that we are having, as I said, probably the people who are living in the metro towns are not even able to appreciate. We look at things in a very, very different way. What we have to learn, at least from NHS, is number one, that a system which is far more developed than us is still looking at innovation. They're still looking at a change. They're still trying to find a solution, while therefore we are definitely needing a far more disruptive change in our country if we want to make a dent towards improving, I would say, the healthcare, especially at the bottom of the pyramid. I think the key for all innovations, if we can try to make it to more affordable, we are having a lot of very good, expensive ways of treatment, whether it is monitors, whether it's a lot of medical equipments. I think one of the innovations has to bring about how do we make things more affordable. The burnout of the doctors and nurses, you have no idea what's happening in our country. I think majority of our good brains are now shuddering to go into the medical profession. And therefore, like what Professor Gupta talked about, actually the good health, that is the feeling of enjoyment, the feeling of well-being. I think if we can concentrate only for our doctors to remain and come to that state of mind, we will do a lot of justice to the rest of the population. At the moment, they are under great stress. Going on to the next speaker, let me invite Dr. Chandy Abraham, who is the CEO of the Healthcare Project ITC Limited.
Good morning, everybody. And I want to, at the outset, thank Dr. V.K. Singh for giving me this opportunity to actually speak about something that I think is extremely important. I think, at this particular time, the hospital industry is facing a lot of headwinds, both from a regulatory point of view, from public opinion. And if we don't get into the act and start innovating in the way we deliver healthcare, it's just going to get worse. If you look at the news recently, you would have seen that a lot of the technology sector, people have actually developed innovation incubators. And they've realized that that's the way forward. But in the hospital industry, it's very difficult to find hospitals that have innovation incubators. I did a Google search to see how many hospitals would turn up if you did a Google search on hospital innovation. And the first page was completely filled with Philips Health Innovation Campus, Medtronic, and the IIT Healthcare Innovation Center. You don't get any hospitals. About the third or fourth page, you get the LV Prasad Institute, Eye Institute Innovation Center, and a few others which use hospitals but are mainly private-led innovation centers. There's definitely a paucity of innovation incubators and centers within our hospital system. And I think very often this is because, in the hurly-burly of operations, we just want to concentrate on what we're doing, on all the issues that face us in operations. But we don't take time to actually see other innovative ways in which we can combat this. And I love this saying by Marcel Proust, who says, the greatest discovery comes not from seeing new landscapes, but in seeing the familiar with new eyes. And I think this is one of the imperatives that we have in the hospital system. We have a lot of cultural hindrances traditionally, and when I talk about cultural, I mean the culture within hospitals. We're highly hierarchical, and we have decades of adhering to regulations and organizational procedures, which is good, but we take it to the extent where it begins to stifle creativity. And this can be a huge problem. Healthcare change itself is very slow-paced, and for a lot of leadership, we've traditionally done it this way. We don't want to do it any other way. This is the way that we've always done it. So this can sometimes be a problem in the way forward for innovation. If you look at one of the most innovative companies that they've talked about in this century, it's Google. And they talk about having a mission that matters. In healthcare and hospitals, we have a mission that matters. We already have it with us. We have a huge mission that matters. And if we start becoming patient-centric, focusing on the users there, and having an open atmosphere, how often do we allow ideas and thoughts from the shop floor to come up? Do we look at people within the hospital system technicians, nurses, are they allowed to start looking at innovations which would then actually feed into the system? One of the ways that I think we need to do this is through what's called the design thinking model. And the design thinking model starts with making sure that you identify the problems that are there and identify that properly. Some of these are very visible problems, but some of them are actually unseen problems. And sometimes what you see as a visible problem may not be the actual problem. I actually got 2 minutes extra, so I'm going to tell you a story. There was a gentleman who actually a philanthropist who went to Rajasthan, to the desert, and he saw all these women carrying pots of water on their head and walking these long distances to get water and come back. So he said, this is where I need to put my philanthropy. So he went, collected a huge amount of money, came back to the village, and he decided, now he'd announce it to all the women, your troubles are over. I've got these 2 wells that I'm going to dig inside your village, and all your problems are over. And they weren't overjoyed. In fact, they all looked a little distressed. So then he started inquiring, and he said, the only time we get to leave our husbands and walk and talk to each other is when we go to get this water. Now we're going to kill that also. So do you see, sometimes what we see as the problem is not the problem. We need to spend time in trying to figure out what really is that human-centric problem that is there. And once we get that, the solutions that we have to be technically feasible. You can have these phenomenal solutions that you have, but they're not technically feasible. And then it needs to be business viable. You shouldn't develop a system where you're constantly looking for funding for it, and it doesn't work. There's a saying that charity is not scalable. You don't have to be greedy, but you need to make sure that you have a business viable solution that is technically feasible and meets the need. The start always is to organize thinking about patient problems. We should shift from this whole idea of trying to fill beds in hospitals to start creating patient value. That's a very different proposition. It's not the same proposition as saying that, I'm going to fill all the beds in my hospital. As managers, as CEOs, very often the whole imperative from the board is, you built a hospital, 1,000-bed hospital, can you fill it? And your success is not in whether you created patient value. Your success is determined by how many beds you filled. And that's completely different. we have to emphasize better patient outcomes. Just a few thoughts in the next few minutes about how you could go about setting up an innovation center. You need to make sure that you gather patient inputs, and I've talked about that. Look at patient care operations. Look at functional departmental operational needs. Talk to people in the departments. And the next thing is the most important thing. If you look at most of the innovations that we do, I've been in a lot of innovative organizations, but most of the innovation is two people meeting on a corridor saying, I've got a problem, here's a solution. Then you call two clinicians together, and you call some administrators together, and very quickly you come up with this whole solution that you then deploy and then iterate continuously. You need to formalize it and start looking at people outside of that domain. Very often you'll find people with new eyes are able to see things that you don't see. And that's where innovation comes from. Start using people like behavioral psychologists, use economists. They sometimes have a completely different view of what the finances are. So get as many people as you can into this whole pool of looking at a problem. Provide time. We don't formalize time. You need to do it on your own time. Right now, you're in the hospital. We need you for operational issues. If you want to innovate, that's on your time. How many people will actually go ahead and do that? Very rarely. So you need to make sure that you provide time to explore and experiment for everybody, right from the shop floor upwards. You need to provide resources for trials and prototyping. And the leadership needs to slowly be imbued with this whole idea that we need to have a culture of innovation within the organization. You need to align innovation with your long-term strategic goals. Very often when we make strategic plans, you will very rarely find innovation, or we just put in that word there, but really nothing to support that. In your strategic plans, you need to not only put the word in because it sounds good, you need to make sure that there is sufficient support within your strategic plan to actually implement that. Good innovation centers are usually institutionalized. They're built on a repeatable process, which means you've got a system for actually collecting ideas, start coning down those ideas, selecting a few, then how do you actually prototype those ideas and then bring it out to market, or inside the hospital if you're looking at service innovation. You need to invest in intellectual property, which means start protecting these ideas, which shows how important they are. And you need to have a possible global intent. You don't have to just think extremely small. I want to end by this saying by Soren Kaplan. It says, most innovative companies don't do just one thing focused on innovation. They create an integrated system of activities that all reinforce each other to shape culture. They eliminate the feeling of risk altogether and replace it with an environment focused on collaboration and learning. Thank you very much.
Thank you, Dr. Chandy, for I think, wonderful presentation and definitely an idea that needs to be looked into, and that is the innovation centers inside the hospital. The only thing that I can try and say is that one of the major hurdles for the hospitals today to even think of innovations in their own setup is the basic economic survival of these hospitals. The important thing is that somewhere along the line, we need to understand the economics of running a hospital, and that's where the hospitals are not able to think. At the moment, the only way they think is, how do I survive economically? And most of the time, they survive by compromising on quality. However, see, through the organization that I represent, that is the consortium of accredited healthcare organizations, what we have tried to do is that how the hospitals can get connected to at least some of the established innovation centers. So we should have a collaboration with them where we are trying that at least the innovations which come are tested in the hospitals, and also the ideas that the hospitals can generate, if they can be passed on to some of the centers, and we are actively trying to collaborate with any of the incubators and the innovation centers in the country. I will, for the next speaker, I'll request my co-moderator, Dr. Shivam Ganju, the gastroenterologist from United States, who has recently come back from Chicago, is a very illustrious person. I'll request him to please take it over. Sir, I have to go and catch a flight. So he will introduce the next speakers as well as conclude this session. Thank you, sir. Dr. Shivam, please, you can invite Kah Yee, Chairman of the Eucharist Hospital in Malaysia.
Thank you, and I guess it's good afternoon now. Good afternoon, Delhi. Good afternoon, India. I just flew in this morning, just past midnight from Moscow, and my luggage bag decided to take one more day holiday there. So I didn't have any clothes with me other than what I had. So I spent about an hour this morning. How do I look? So I just got it this morning. Struggling with the shopping mall that they don't really open at 10. They open at 10:30 or so. Anyway, now I look like one of you. All right, I'm going to talk about the more like technology changes or revolutionary changes and the opportunities in the healthcare industry in the recent year and obviously going to the future. The company is a group of companies. It has two listed companies. One of them is called InnovatioCuris, is the company that developed a online healthcare concept of virtual hospital platform. We started that up 6 years ago and has been operating for 2 years now. The other company is also a listed company. It's a semiconductor chip design company. It's public listed as well. Has been around for 10 years. And recently, for the past 6 years, we aligned the company to develop chips that focus on the healthcare industry as well. Namely, one of the chips that we've done is IoT chip, Internet of Things. And the other chips that we have done is AI chip, which I'll talk about also a little bit later on in the presentation. We also have a United Crest Capital, which is an investment company, where we invest in largely in the technology companies, also in the service industry as well. We also have another company that's set up specifically to operate the cloud hospital or the virtual hospitals in China and other parts of Asia. We have offices in Singapore, Malaysia, Taiwan, Shanghai, and Beijing. I live in Singapore. Now, here's my background. I'm not a doctor. I started my career in Silicon Valley as a chip designer in the semiconductor. I've been doing that for about 30 years in the semiconductor industry. About 6 years ago, you know, in the process of making investments, we've seen a lot of companies that came around from the US, from Europe, looking for investment in the area of online healthcare. They call it the online healthcare, but typically you get 1 or 2 devices like blood pressure monitors or glucose meters with an app, you know, then they say they can monitor your health. So as I get deeper into it, then I realized that, you know, doctors don't look at your health by just looking at 3 or 5 numbers from the device, right? So the doctor actually need a full medical record, you know, all the blood tests, urine tests, and whatnot, in order to decide or diagnose what the disease that you have. So then I came up with the idea of all these apps and devices is not going to work by just having 2 or 3 devices hooked up to an app. Doctor is not going to do the job. Doctor is not going to be able to decide. So I came up with the idea of a virtual hospital. So that's how we started. So now I'm the chairman of those 2 companies and also some of the investment company or those companies that we have invested. I'm going to talk about this technology that are recently hot in the technology world, but applicable in the space of healthcare. The first one is online healthcare. I'm going to talk about the online healthcare. Next is Internet of Things, IoT. A lot of you, I'm sure you know about it. Blockchain. How many of you are familiar with Bitcoin? Or how many of you actually have Bitcoins? You guys are gamblers. All right. So I guess you never think of blockchain in healthcare, right? You think of blockchains and Bitcoin, that's all you think about, right? Getting some machines and make some money there. All right. Artificial intelligence, AI, right? So that's the next big thing. I guess a lot of you heard about big data. Big data has been around for a long, long time, for the last few years, a lot of talk around it. And then online clinical trials. Now, all these technology topics that I talk about here is something that we have done, one way or another. Some of them are pretty complete, some of them are still in the process of being done. So let me just go through one by one. Hopefully, it's already half time gone. So hopefully I can get through this, and I'll talk about the opportunities that come along with this technology. Online healthcare, we developed a virtual hospital system called the iMedic. It's been around for about 2.5 years now, operational. Have hundreds of thousands of patients on it, and we have thousands of doctors seeing patients online. Of course, some of you who are doctors would wonder, how the hell do you see patients online, right? Obviously, things that you have to see physically, you go to hospital. If you need a surgery, you still go to hospital. If you need to take a CT scan, you go to hospital. But if you need to go in the hospital, just get your blood pressure, get a few vital signs taken and all that, and spend 5 minutes or 3 minutes with a doctor, especially for your chronic diseases, you don't have to go to hospital. You can probably do it online. Just like many of you, after you see a doctor, to follow up, you probably WhatsApp the doctor or email the doctor or call the doctor, right? So it's no different from what you have been doing in the past, except now you have a better system, a system that has all the medical records that allow you to communicate with the doctors easier, and the doctor have access to your data anywhere, anytime. So this is how the system works, an app with the patient that hook up to multiple devices. Right now, hook up to about 26 or 27 devices, ranging from small devices to big devices like CPAP machine for sleep apnea patients. Now, all these have to be FDA medical devices or CE medical approved devices. It's not the Fitbit, the gadgets, all medical devices, because doctors need to have FDA approved devices in order to diagnose the patient. So patient take the measurement as required on a daily basis or regular basis, upload to the cloud, and doctor will be able to have access to those data, including the data from the hospital. So that's how it works. And doctor would have an app. Anywhere they go, doctor can actually continuously, doesn't matter where they are, they can actually diagnose the patient or provide medical service to the patient. Now, online healthcare opportunities. Well, it's a long list here. Once you have the system up, right now we work with not just the doctors and the hospital, but all stakeholders in the healthcare industry, namely the pharmaceutical companies, as well as the insurance company. All of these guys are interested in getting hold of the data, better programs with the data. For example, let me just go through it quickly. Some of these services are already provided right now. It's borderless. You can right now, if you're at the doctor, you're at a hospital, you see patients only when you're in the hospital. But once you have an online system, then you're making money even the patients are not in the hospital. Online doctor appointments, these are quite a common one. Online pharma, people buy prescribed drugs, doctor prescribed drugs, and you get it delivered to you. Pharmaceutical company, we're running some of these programs now with pharmaceutical companies. How to have the patients to be more compliant to the medication taking. If they're supposed to take once a day, they take once a day rather than once in a week. So some of the other programs are like the patient feedback programs, loyalty programs, and even online clinical trial. We work with one of the cancer research institute, the largest in Europe. Turns out to be based in Moscow. We're doing some cancer research, clinical research work with them. Online medical consultation, this is the obvious one, doctor to patient online consultation. We call it the D2B, D2P, and also we have those doctors from the Center of Excellence. If you have a hospital group where you have a bunch of specialists in one hospital, and they would be able to support other doctors in some other hospital. That's what we call it, the D2D2P. That means doctor, a big doctor, talking to a small doctor, talking to a patient. Online DMR, digital medical records, this is the one that is the most important. It took us a lot of time to get this hooked up and get this all integrated into our systems. And finally, the online insurance. So insurance company are also getting into online business right now, other than selling the insurance policy, but it's also online direct payment, online claims, as well as some of the incentive program to the policy holders. So that's the online technology. Now, the Internet of Things, IoT, this is the familiar one. I'm sure you guys know about this, the Fitbits, those devices that you wear and run and jog and all those that track of your data. Those are part of the IoT. So if you look at the front end, patient have the wearable devices, home devices, wireless devices that they put on and get the data. But at the back end, the hospital also need to get those big equipment data connected to the network so that the data can go up to the cloud directly. If you look at the hospital today, the data from the images from the machines, they are connected to the HIS system or the EMR of the hospital. So to get those data out to the cloud is extremely difficult. In fact, it's almost close to impossible. So the way that we did it was we designed a chip in the form factor of USB. If you look at that, it's called the M drive. The other one is called the M card. In the form factor of USB or SD card. So as long as the device had a USB slot, then we can take the data out and send it to the cloud. As long as the device has a SD slot, then you get the M card going there and take the data out. So by doing that, we have a chip that connects the equipment in the back end, and without disrupting the operation of the systems in the hospital, we're able to get the data out to the cloud. We filed a patent this about 5-6 years ago. We have patents in all these countries that design chips: US, China, Japan, Singapore, Taiwan, and Korea. IoT, the opportunity for this is really the hardware guy, right? Guys that design chips, guys that makes equipment, for example, Philips. You know, these are the guys that make a lot of equipments. You notice that over the last few years, the equipment has gone from a large, big machines in the hospital into a much smaller, portable ones. For example, ECG these days is just like a barcode scanner. You know, in the old days, some of the hospitals still have those on a big wheel, and you wheel it around the hospital, right? Many of these devices is going to be miniaturized into a very small device in the next few years. Now, once you have the devices connected, of course, then you get a lot of data, right? So these are the devices that we connected today. And of course, you know, there are more and more devices coming out. Some of those are 2-in-1, 3-in-1. For example, blood pressure monitor goes with the oximeter, goes with the ECG. So eventually, just like your phone, you know, over time, other than just making calls, you can do data, you can do Wi-Fi, you can do many things. You have cameras going into it. That's what semiconductor guys do, integrating things 3-in-1, 4-in-1, 5-in-1, eventually everything into one. All right. So these are some of the bigger equipment that we have connected. Fundus camera that's used to detect, even take pictures of a retina. You can detect quite a few types of diseases from this. We also connect to the CPAP machines, and we also connect to some of these physiotherapy machines. Blockchain. It's not Bitcoin, my friend. This is healthcare. So if you look at the blockchain characteristic of blockchain, there are three things in there. Number one, decentralize it. Today, data are in a mess, if you will. No hospital has your full history of your medical record today. You go to multiple hospitals, they all have an instance of your medical record. Nobody has all of it. So this is good technology that will be able to aggregate all of your data together. Immutable, something that you cannot change, right? So fraud is not possible. And smart contracts. So these are the features in the blockchain, is 100% applicable to the healthcare industry. So what are the opportunities there? Then of course, it's a change in the HIS system. So some of you who are in this business, here's the chance for you, here's the opportunity for you. And by doing this, you can also build a fully aggregated personal medical record. That means all the patients, no matter which hospital they go to, they get to see this. They have the full medical record. So only when you have a full medical record, then you can do analysis on your data. If you are part of it, then it will not work. AI. So we did the AI chip, called it the AI engine. It's able to learn, able to decide, that means diagnose, and also able to put in the knowledge of the specialist into the system. So two areas that you can use it for: diagnosis and also as well as treatment. So what we have built is we've built a box. We call it the AI engine box. The first target that we have is to recognize cancer cells. Leukemia is the first cells that we recognize right now. We have a 95% success rate, or accuracy, if you will. We are actually working with one of the professors at IIT here, of course many other professors as well. We will have this product out soon. The other area of the AI chip use is to sort the cells, just like what we did. Sorting cell means looking at blood. If you take blood samples, then you can have a chip that go through and figure out what kind of cells, how many cells do you have, just like your blood test machine right now. So eventually, the blood test machine that you have in a hospital will be a little kit that you send to home, disposable, maybe $5, $10 each. Big data. So as I said earlier, you have to have a full history of the personal data of the patient. If you don't have the ability to do so, then the big data is not quite a big data, it's a bunch of garbage. Once you have the data continuously and aggregate it together, then it's meaningful to start mining the data. Again, this is a big business for the pharmaceutical company. They like to have this data, more so for the insurance company. Sorry. This picture is just to show you that data from all inputs, including the lab biochem test, imaging, medical devices that are at home, and that doctor's diagnosis are all integrated into our system as one system right now. My time is up. Let me just give you the business model. Today, every dollar that a hospital makes, patient has to be there. Patient has to be there before you can charge them, whether they're inpatient or outpatient. With the online, where you can provide the medical service online, then patients is away from hospital, and yet you'll be able to charge them money. One obvious thing is the step-down care. Patient comes in for surgery. After they're discharged home, they still need the extended care. With this technology, then you can continue to look after them even they are away for 3 months, 6 months, for a year, or continuously for the rest of their life. Now, for patients that are not quite sick enough to be hospitalized, but sick enough to be managed, then you also manage them. So we call that the preventive care, pre-hospitalization. The other business model is the doctors. Some of the top-notch hospitals have a bunch of specialists, for example, pathologists. You know, not every hospital have pathologist group. So a hospital that have pathologist group will be able to extend the service to other hospitals. So what we call that is from the center of excellence, the D to D to P model. So we did quite a few projects. One of them is a Shanghai hospital called Hospital Number 10. Their responsibility is to look after 134 hospitals nationwide in China. So the specialists in this hospital in the past, all they can do is run workshop twice a year, but now they can actually do the on-the-job training or joint consultation with the patients through the systems. Opportunity for farmers. We work with the pharmaceutical company, as I said earlier, on a loyalty program, adherence program, and also finding new diseases with the patient and promote new drugs to them. And obviously, earlier speaker also talked about the value system. Instead of just filling up the hospital bed, the outcome of the patient is what they're looking for. Same thing with the insurance company who are paying the medical bills for you. They're looking for better results. So through the system, through the collection of the data, analysis of the data, then they have the ability to prevent a bit of a fraud and also promote value-based systems. So here's a takeaway from my talk here. Changes are here, whether you like it or not. We talk about affordable healthcare. You know, your Gucci bag or your Chanel bag that you pay $5,000 for in a retail store, if you go online, it's probably $4,500, right? It's cheaper, right? Same thing, anything go online will be cheaper. Technology make things cheap. Online service, healthcare service will help to reduce the cost, obviously with the innovation models. All parties in the healthcare, all stakeholders will have the opportunity to help to improve this. And you will see that pharma retail store, just like many of the retail store, Walmart and things like that going away. As soon as the online business taking off, a lot of these things will go online. And finally, government has to play a role because healthcare is a heavily regulated business. Doesn't matter which part of the world, they're all regulated. And to help to accelerate this process and help to reduce the cost of the government, and also help to have affordable healthcare, regulation change is needed. Thank you very much.
Our next speaker is Amarjeet Singh. And without much ado, please, Amarjeet, take the podium and say a couple of lines about yourselves. I'll make it brief and sweet.
Good afternoon, everyone. Good afternoon, Dr. Ganju. I'm Amarjeet. I represent a Swedish organization called Getinge. We are into healthcare for last 100 years, and it's not only a 100-year-old company. We are with healthcare for almost 170 odd years through our products, which we acquired later on. So I'll briefly touch upon the history, our landmarks. We are currently based at Gothenburg. We started from a small village called Getinge, and therefrom, name Getinge comes. And it started in 1904. We are primarily into two segments, healthcare and life care. Life care like bulk manufacturing and healthcare. So Getinge is primarily known for infection control for bulk manufacturing companies, pharmaceutical company, or your parenteral drugs. On other hand, I represent the vertical, which is healthcare. In healthcare, our journey started somewhere in 1936, but more aggressive we became in 1989, where we acquired lots of portfolios and product portfolio. So primarily, we can divide our portfolio into two segments. One is the acute care therapies, where we have, heart-lung machines. We have ECMO, which is, very advanced miniature of heart-lung machine, which is used for over a period of time. We know about our former Tamil Nadu Chief Minister was put on this machine, and this gives extended lease of life. We are market leader in ventilators for almost 15 years in India and globally. When it comes to surgical work portfolio, we are infection control company. We provide equipment, but more than equipment, our emphasis is on design, philosophy, and processes. And apart from it, we acquired a portfolio called Mackay, which is a German origin company, which is 175-year-old company, which was the innovator of first operation theater table in the world. So this is the innovation legacy that we have, but we are now gradually moving toward the solutions and productivity enhancement. Yeah, we are a very strong medical device company. I will touch upon, this fact that today we are speaking about cost, how to reduce cost. Most of the healthcare companies, they focus on the numbers. Whenever we see advertisement, we have done so many joint replacement numbers. We have touched so many patients. But do we speak about the success rate or outcomes? Do we speak about the survival rate of the cancer patients? So the focus is more of on the number side. And on the other hand, there is a regulatory pressure, price pressure, so the cost has to be less. So on one hand, we are trying to reduce the cost. On another hand, we are focusing only on the numbers. So this is an endless game, unless we will not focus on the value. So value is what you derive out of that cost, what outcome you will get. So the focus will be on outcome. So this is where we are currently working. And we believe healthcare facilities, if it is planned better, it can serve more patients. In India, if you will see operation theater, how modular they are. Do you have the flexibility to change their structure later on? How much it would cost? What will be the turnaround? What the expenses? Nothing is planned in well in advance. There are hospitals, big hospitals, planned without dirty corridors. So the fresh instrument comes from the same pathway where from the used instrument goes out. So that's not a healthy practice. So definitely a hospital-acquired infection rate will be higher. But the moment we discuss this thing, then we have a solution called antibiotic. So prophylactic use of antibiotic is very high in India. So this is the one segment where we work, architectural planning help and assistance, how your instrument should be reprocessed, where from your patient should come, where from your consultant should come and go. Second is sterilization products. We are a sterilization company, so we provide architectural help. Apart from it, traceability of the instruments. Instruments are very premium nature, means liver replacement tray cost almost like 1 crore rupees. So one instrument missing is like you are opening a tray, right before surgery, and you realize there is one instrument missing. There is a cost. Cost of sterilization, cost of operation theater, cost of manpower. That cost is not being captured. So we provide a complete traceability. Who sterilized it, where the instrument location is, when instrument got missing, when instrument need to be replaced or should go to the servicing. And third is the patient flow management, which is clinical logistic. So I'll not touch upon architectural planning. This is a very deep subject, and so is the sterilization. So today I will be focusing more on the clinical logistic. We all have been to the hospital. We know, there is a desk where you are enrolled or registered. But how many of us, if we are scheduled to see a doctor, can see a doctor at right time? Or we are scheduled for a surgery. I have taken my parents to hospital for bilateral knee replacement, and I have been working as a sales rep in the same hospital for a very long period of time. I know everyone there, but it took me 3 hours to get the bed, and it's one of the leading corporate hospitals. So if corporate hospital cannot allot a bed at right time, then you can think about the public sector. So this is the 3-zone concept that we follow. There is a red marking, which is an unsterile zone where reprocessing happens, the green zone where the sterile goods are kept, and the in between is the clean zone where sterilization takes place. So there has to be a flow of patient predefined, flow of instrument predefined. So that's where we put our emphasis on. So today, I'll focus on some of the stats, which is meta-analysis, that what are the core challenges, where lots of money is being spent, which can be saved. Hospitals are wasting almost 27% of their revenue on the inefficient processes. And these are the figure of US, $711 billion US dollars. There, and this is a figure of 2060. So in 2016, there were 3.3 trillion. There was 3.3 trillion allocated for healthcare spend, out of which almost 27% has gone waste. I'll not touch upon many countries. I have those figures, but where by and large those spend is happening, excess administrative cost, inefficient care given, unnecessary services charged, prevention of failures. So there are different aspects, but more or less 30% of the health spending is being wasted. And that's a very big number. And in India, we don't really have the data. So we cannot really say how much we are spending. How much is the wait time for the patient to get the bed? How much is the wait time to get the right doctor? When patient comes with the comorbid disease, there are multiple disorders needs to be addressed. So there are multiple clinical teams, and their timing, when those people will see, means clinical team will see the patient, is not defined. So communication delays are also a problem. So if you will see the coordinating nurse, especially in OR, so she has to coordinate with ward, whether bed is available or not, OR is available or not. Surgery is getting delayed, it has to be communicated to the surgical team. ICU needs to be ready, and so on. So this coordinating person, he's busy. At the same time, he's chasing doctors. Doctor who's doing surgery cannot take calls. He has to ask someone to pick up his call and give answers. So this is like wastage of time, productivity, and efficiency. So to address this, we have solutions. So every department has developed their own solution. Laboratory has laboratory information system. Finance team has their finance system. HR has HRMS. All department has their own solution, but those systems doesn't speak to each other. OR scheduler will not speak to the laboratory scheduler. So a patient who's, admitted in hospital due to polytrauma needs to be seen by multiple people, but he don't know when he's slated to, the next diagnostic test or next clinical team. And there, the communication is not dynamic. So there we have actually developed solution We have Insight as a solution, Insight Emergency, Insight Surgical, Insight ICU, and Insight Patient Ward. This is a master integrator. Right from ambulance, it starts right at the patient's discharge. So it gives a very good clinical experience to the patient as well as to the clinical team. These are different modules. It works independently. It can be given together. So how it will improve hospitals? Average length of stay will reduce. Hospital-acquired infection will reduce. Readmissions, cancel surgeries, waiting and other risk related to this. And it will also improve the patient throughput, operation room utilization, medical asset utilization. So this is a master integrator. So I have one small animation to show which covers.
McKay introduces Insight, the clinical logistics solution. This is Peter. Following an accident, he arrives at the hospital. His information is immediately entered into Insight. After a first assessment and blood test, a nurse takes him to the radiologist, who already expects him thanks to an alert from the Insight software. An X-ray confirms a leg fracture that requires surgery. Within the Insight system, Peter's information is now automatically communicated to the surgery department, and Peter is transferred to the surgical ward. In preparation for the surgery, the central sterile supply unit is made aware of what equipment is needed. Via Insight, the staff has an overview of all the relevant information in real time. The coordinating nurse knows exactly when staff, OR and equipment are available. Without the hassle of checking a whiteboard or making phone calls, she can easily book everything that's needed for Peter's surgery. The system then alerts the required staff on their mobile devices to arrive at the OR at their assigned time. During the surgery, information about the procedure is entered into Insight, and other departments can monitor Peter's condition in real time. Even Peter's implants and instruments are easily stored into the TDoc system. When a surgery takes longer than planned, the system automatically reschedules the following procedures and alerts the people involved. Furthermore, via an interface, the information is automatically transferred into TDoc, which can then automatically reschedule the supply of instruments. 30 minutes before the procedure finishes, another automatic message gets sent. The staff now know to have the recovery room ready and to return for Peter's transport to the patient ward. Even the cleaning crew and sterile unit can arrive at the perfect time to clean and resupply the OR before the next surgery. While Peter recovers from his surgery, the Insight keeps track of the next steps in his care, including medication schedule and rehabilitation. A few days later, Peter leaves the hospital, feeling pleased that he was well taken care of. The staff are pleased as well. They can work efficiently thanks to Insight and its cross-functional features, optimizing communication and coordination and overall workflow throughout the hospital. And last but not least, Janet in management is pleased. With Insight, she can now analyze the hospital stays of patients like Peter. This will further help optimize workflows and efficiency. Insight, the clinical logistics solution. McKay, the gold standard.
So this is a brief animation which explains about entire patient's journey and the different modules which covers their journey throughout. I'll not take much of the time. My time is up. Just one more stat. We have implemented same solution across the Denmark. All Denmark public hospitals are using TDoc, which is our instrument tracking device, and our patient flow management system. And this is what they are getting out of it. Almost 50% of the less time being spent, almost 9.3% productivity increase. So that's a revenue increase. At the same time, we are saving time. In India, yes, when we save time, we say, okay, we can hire more people. The cost of people are not high, but at the same time, we will be able to serve more patients. So we also serve the number games. Then this is what the reduction happens, 28% reduction in adverse event, 19% productivity increase, 4% OR productivity gains, And then we have 10% reduction in average length of stay, which is a revenue for hospital, 23% increase in discharge, 39% reduction in the phone calls. So in Denmark, I've been to Denmark and seen their multiple hospitals connected to each other. And really, they don't use mobile phone to communicate for their clinical purposes. It's only for personal purpose they have to use their mobile. Everyone can send alert to anyone. So there is a module for people to communicate over phone. So there is an app through which they connect. And by this, we increase productivity. This is another one of the stats from Germany where we have implemented in five major hospitals. And this is what the stats of OR utilization, 14 days of average length, and 14 million numbers are there. So you can see the number of operation is increasing and average length is decreasing. So this is the difference that a better, efficient software solution can bring. So this is from my side. However, as a medical device company, this explains us better from Indian perspective. We don't have these solutions as of now in India, but very soon we will have some of the installation in India. So thank you very much for your patient hearing. You've been very grateful. Thank you.
Thank you, Amarjeet. How much time do we have a Q&A? Do we? How many minutes? I want to be a good timekeeper. 15 minutes for Q&A. Anybody, let me start a question while you get ready. This is to Chris and Chandy. What's the optimum size of a hospital nowadays? Is it 300 beds or 1,500 beds? Now they come from different perspectives. Chandy comes from Narayan Hyderalaya, which is the minimum size has to be 1,500 or 5,000. NHS is much smaller. The hospitals are almost like ICUs, and the rest is all done outpatient. So what's the optimum size? I'm talking from optimum cost point of view.
Yeah, no, I think you sort of partially answered that question. More and more hospitals are becoming acute care facilities. And chronic care shifting out into the outpatient realm. So I think from the traditional, behemoths of about 1,500 bed, they're all coming down, I would say, about 700 to 500 beds. So bed size is actually coming down. So that's very clear. Some of the things that could drive bed size up is if you have a medical school, if you have educational programs, those kind of things have a certain requirement which would actually push the bed size up.
And it's actually interesting because in the last 10 or 15 years in the UK, there's been a huge thing of this kind of public-private finance initiative where in London in particular, very large hospitals have been built with up to 1,000 beds. The evidence is they're not that productive. And there's a very real challenge for the leadership to be able to control it, and more importantly for the directors of nursing and for the medical directors to actually maintain the quality and the efficiency. So what they're beginning to see is more like medical cities and perhaps the way forward, where they are smaller individual units with a hub and spoke model providing the services that require those units to work. So that is definitely the trend. In my personal experience, at 500 beds, you can be optimum in efficiency, the management can manage the organization. When it becomes bigger, the complexity becomes exponentially greater.
Questions from the audience?
My name is Jagan. You mentioned about the virtual hospital. One of them, you also mentioned about, you didn't touch upon the virtual clinical trials, basically, because for an innovator, clinical trial is one of the biggest trouble, and also getting up to the FDA is another biggest trouble. So just wanted to get your vision on that.
The system that we built pretty much track all the vital signs, and it can be created as you go along. So if you find new vital signs that you need to add on the system, you can actually add on the systems. Today we have about 2,000 parameters in that, and it's still increasing. We didn't start off this to be a system for clinical trial, but as we go along, we realize that some of the research hospitals, especially University Hospital, they are interested to have the system extended to the patient so that you pretty much not just track the patient, but also make it a reminder to the patient, especially in the process of taking medication. When you have a bunch of patients out there, let's say 3,000 patients for your drugs clinical trial, getting the adherence to the medication usage is challenging, and there's no way to track them. A lot of times you have missing data, and you have patients that are not taking those in accordance to the instruction. So by having a system out there, remind them constantly do that, it helps them, one, to track the data, also increase the adherence of the patient. That's one. The second thing is that as you go along, the back-end system actually analyze the data, chart the data, and produce actually reports at the same time. So you can get the data online. You can get the analysis done by the system automatically as you go along. So you don't have to wait for 3 years or 5 years to get to the final results before you get to get the report out or do the analysis. Right now it's done that way. You collect the data, then you do the analysis at the back end, right, very late stage. But right now you can actually track the trend and see whether you're actually in the right direction. If it's not, then you make changes along the way or abort the clinical trial.
Any more questions from the audience before we?
I have a
Okay,
question.
go ahead. One, and we'll take one more after this because I'm getting signs for me to wind up. Please.
Yeah, hi, good afternoon, everyone. My name is Preeti Rao, and I run an organization called WellG that's focused on sustainable lifestyle habit change based on the neuroscience of behavioral change and behavioral psychology. So my question is for Dr. Abraham. You talked about behavioral psychology as part of a model within the integrative health setting, because that would lead to prevention and management of a lot of chronic lifestyle diseases that are stemming out of poor lifestyle choices we make. So I was wondering if that is already embedded in your existing model, or you're looking at embedding that in the future, and what do you see the future of that? Thank you.
I think I was talking more about when you look at innovation, you've got to make sure that you have all aspects sort of looked at. Traditionally, we just go for the clinician and the administrator. They both sit together and make the decision about, what's the next new thing that needs to be done. But it's not only behavioral psychologists, I think, economists, everybody needs to look at it. And then you begin to get a completely different view or different eyes on the subject. And then what happens, your innovation becomes more real, it's more holistic, it's more sort of centered on the person as a whole. Because, very often as a clinician, if I'm a colorectal surgeon, I'm going to just focus on that. And the innovations would be all sort of centered around structural disease. Whereas, there's a whole spectrum that needs to be looked at if you're being very innovative.
One more question. Well, none, and we will break for lunch. I just have a question for the audience and everybody else. This innovations focus, I can see, was more tertiary care, high-tech hospitals. The problem is we don't have enough hospitals, at least in India. We would like to see an innovation where we have low-cost hospitals providing optimum care to the poorest of the poor. 60% of the people are poor, they still can't afford any health care. I have no answers for that at the moment. If anybody has any answers, tell us at lunchtime. And also in the world of innovation, the function of innovation is to I'm a provider, I'm a doctor. So my point of view, reduce my cost, increase my revenue, send me home a little earlier. In my science of innovations, I've yet to see a single gadget that's done all three. They've increased my cost, cut my revenue, and I go home 3 hours later. Thank you.
Thank you so much for such an interactive session, and I would now request Dr. Shibin Ganju to please give a small token of love and appreciation to Chris Lloyd, Senior Advisor, IBM Watson Health. Thank you so much for joining us today. May I request you to please give a small token to Kah Yee, Chairman of InnovatioCuris Group Malaysia. Thank you so much for joining us. To Dr. Chandy Abraham, CEO Healthcare Project ITC Limited India. Thank you so much, sir, for joining us today. And last but not the least, Mr. Amarjeet Singh from the Gettinge Group for joining us today. Thank you so much. May I request Rear Admiral Vijay Singh to please present a small memento to Dr. Shibin Ganju as well.
This belongs to the moderator.
No, it's, we are really pleased to have you amongst us today, and thank you so much for sharing your experience with us. Thank you so much. Can we have a round of applause for all our speakers and everybody who are present here? Thank you so much. Thank you so much. Sorry to say this, but we have only 40 minutes for the lunch because some of our speakers have flights out and we don't want to miss out on the experience. So please join us back quickly after the lunch. Thank you so much.